first presentation. And I'm very happy to introduce Dr. Gabriela Equihua Martínez, who also mainly organized this webinar together with me. Thank you very much. She graduated from the Autonomous University of Baja California and worked in rural areas of Mexico as a general practitioner. And after she then obtained a master's degree in public health from the London School of Hygiene and Tropical Medicine, she has been working since 11 years in the outpatient clinic of the Institute of International Health at Charité Berlin. Her current focus is clinical patient care, as well as research on NTDs, migration, and global health surveillance and outbreak detection. We are very pleased to have you here. She will give a talk titled Leishmaniasis in Mexico, Endemic Patterns and the Clinical Challenge of Imported Disease in Travelers. Thank you for joining us, Gabi, and I will hand over to you.
Thank you very much for the introduction, Antonia, and welcome everyone. It's a pleasure to be here today to be speaking about Leishmaniasis in Mexico, this important neglected tropical disease, as well as the important imported cases of Leishmania in returning travelers in the Institute of International Health. Next slide, please. I'm going to begin explaining what the colloquial term of cutaneous leishmaniasis in Mexico is. This is the chiclero ulcer, because chicleros are workers in Mexico who harvest gum or chicle that is used to produce cow gummy. As you see here in the image on the right, they climb on the trees and carve the bark out in order to gather the sap at the bottom of the tree. And their workplace is tropical forests in the south and southeastern part of Mexico. They are heavily exposed to sandfly bites, and they have frequent lesions on exposed sites, such as their face or their ears, as we can see here. Next slide. Leishmaniasis has been present in Mexico for thousands of years. As we can see here in this archaeological find, this culture has a clear evidence of cutaneous leishmaniasis on its right face, but it was first described in Mexico in 1912. It's classified as a New World leishmaniasis that occurs throughout the Americas and has been a mandatory reported disease only for approximately 40 years. Not to forget, the classification and understanding of leishmaniasis are due to the discovery of the pathogen by Leishman and Donovan. Next slide. I have here the biome distribution of Mexico. Our country is quite large, with a total surface area of almost 2 million squared kilometers. On the northern part of Mexico, we have very elevated temperatures with desert and low humidity, whereas on the southern part, we have lush forest and jungle. These are the jungles of the Lacandon jungle and also the ruins of Calakmul that we see here. The bottom parts, the southern area of Mexico is very endemic to Leishmania. Next slide. Who is the culprit of transmitting Leishmania? This is a vector. It's a small fly that's approximately 1/3 the size of a mosquito. These are very poor flyers and have hairy wings. And the primary vector is normally Lutzomaya olmeca olmeca. These little insects are nocturnal, and the females are hematophagus and search for a blood meal. And they can bite any mammal, be a pet dog, a sloth, a human. And when these animals are infected, then they, about a week later, can also transmit leishmaniasis themselves. So this is a disease that is between reservoir and human, so infection. Next slide. There's approximately 1,200 different Leishmania carrying vectors in the world, but in Mexico we have maybe about 20 to 50 different flies that can actually transmit the disease. We see here the life cycle of Leishmaniasis, and just to remember, this is a parasite that is obligated intracellular. It seeks a place inside a macrophage and has a sylvatic cycle as well as like a cycle in a human. Next slide. I have here the distribution of the different Leishmania species in Latin America. As we can see in Mexico, we have the prevalence of the Leishmania mexicana complex, and we also have the Leishmania brasiliensis. In other parts of Latin America, there are also endemic Leishmania species, but they're also very overlapping, so they don't only stay in the confines of each country. And due to migration, there's also different species overlap. Next slide. Approximately 9 million people are at risk in Mexico of contracting Leishmania according to the region where they live. The most endemic areas of Leishmaniasis are in 13 different federal entities in 3 distinct geographic regions. We have the Pacific region, we have the Gulf of Mexico region, and the Central region. But out of the 32 different federal entities in Mexico, 22 of them have presented Leishmania cases. Next slide. Here we see just a rough overview of the different species that are spread out through Mexico. And we can see in general that we have a prevalence of cutaneous leishmaniasis. That's number 1. Approximately 99% of all of the cases are cutaneous. We also have mucocutaneous cases, and other cases such as visceral are also a rarity. Next slide. As I mentioned before, these are 3 different forms of clinical manifestation of leishmaniasis. The cutaneous form can be a single to multiple lesions in different parts of exposed body parts that can leave lifelong scars, and especially if there's superinfection, can cause disability and stigma. And the mucocutaneous leishmaniasis has affection of the mucosa of membranes of the nose, of the mouth, or of the throat. And visceral leishmaniasis is characteristic with irregular bouts of fever. Patients refer weight loss, and we find hepatosplenomegaly as well as pancytopenia. Next slide. I have here some images of classic cutaneous leishmaniasis. The first 2 slides are in different body manifestations. As you can see, there are some similarities, but to physicians that have never seen this disease, it can often be confused with like an infection, just a bacterial infection. On the right side, we see a disseminated leishmania patient. Next slide. Mexico counts with very robust national diagnostic and treatment guidelines. I'd like to thank Dr. Enrique Reyes Novello from the Autonomous University of Yucatan that provided the very newest guidelines. I put the link on the very bottom if somebody would like to go a little bit more in depth to read about what Mexico has to offer. Next slide. In Germany, we also have national diagnostic and treatment guidelines. These are due for revision currently. They are provided by the AWMF and include pediatric and adult patients. We also have here in Europe a group of European countries that gather together as a Leishman group, and they are also responsible of emitting recommendations for therapy. Next slide. How do we diagnose Leishmania? As many of you know, the gold standard is direct, so observation of the Leishmania amastogote. This can be obtained through skin scraping or biopsy from the ulcer edge, very importantly on the edge of the lesion, because it's a common mistake to obtain the lesion from the middle of the ulcer, and this will not be a successful sample. PCR is the standard molecular diagnostic test, in particular to differentiate the different subtypes of leishmaniasis, and serological tests are mainly reserved for visceral form. We have further supportive research tools such as genomic sequencing and culture, but these are mainly reserved for very research purposes. Next slide. Here we can see the classical morphology of Leishman-Donovan bodies that are visible on a direct smear. And not to forget, these amastogotes find themselves inside the macrophages. Next slide. I'm not going to go very much in depth as far as the treatment modalities, just in general explain that there's local therapies and systemic therapies. In Mexico, the intralesional antimonials is what we standardly use, depending on the size of the lesion. There's also thermotherapy that can be applied. And as far as systemic therapy, there's miltefosine and amphotericin that is the first line therapy for the visceral form, as well as pentavalent antimonials. Next slide. There's also some research groups in Mexico that are currently looking for alternative therapies to Leishmania in medicinal plants that have anti-Leishmanial activities. Next slide. And now I'd like to move over our focus to Germany. We performed a 23-year analysis of the patients that had returned from the Americas with cutaneous leishmaniasis in 2024 with our leader, Dr. Andreas Linder. And here we were able to see what dynamic we had from returning travelers in general. And there it was then our surprise that we suddenly saw a lot of returning travelers from Mexico, whereas during this case analysis, we had not had any cases. Next slide. Many of us here in the Institute knew that there was a development of a train, in the Maya train in Mexico. And then we started to really assess the reason why these patients could have a surge of Leishmania. I have here a map of Yucatan on the right-hand side, and I'm going to put a little star so we can know where each patient from the cases that I will explain contracted Leishmania. The first case is a 57-year-old German archaeologist that had been working more than 30 years in Mexico and was living at the time in Campeche. And she had a 6-week history of a very progressive enlarging ulcer on the top of her left eyelid. She lived in a jungle field camp with her team, and she mentioned that several members of her team had developed similar skin lesions. We performed PCR and confirmed Leishmania in this patient. Next slide. This case can be found in more depth online on our Case of the Month series called Trophy Cases. The link is found at the bottom of the slide, and you're very welcome to browse the case that we have recently in the Institute of International Health. We have multiple cases there. Next slide. Going on to case number 2, we had a 23-year-old Mexican male from Bacalar, Quintana Roo. He came here on vacations to Europe, but had been previously diagnosed 4 weeks previously with leishmaniasis and had been treated with itraconazole. He had not responded well to the therapy and attended our outpatient clinic with very marked inflammation, a very weepy ear with suspected bacterial superinfection. The PCR also confirmed Leishmania mexicana in this patient, and treatment was initiated with clindamycin and miltefosine. Next slide. We had a follow-up on this patient, and you can see how the anatomy of the ear was really influenced when the patient came to our outpatient clinic. That's the slide on the left. And the image on the right, we can see what the patient's ear was after the follow-up. Next slide. The third case that we had was a 35-year-old Russian female that had been living most of her life in Germany, but left to live in Tulum and had been spending more than 2 years there. And she noted a cutaneous lesion on the medial part of her right knee that had 3 months like development. And when she returned to Germany, she sought us to see if she could receive a treatment because there was a short of medication at the time. The biopsy was performed and PCR confirmed Leishmania, and therapy was prescribed. Next slide. So all of these patients that have the stars or contracting the Leishmania exactly on the roots of the Tren Maya. Next slide. We contacted our network here in Europe and together with French and Belgian colleagues, presented our findings in this manuscript. Next slide. And the Tren Maya is a mega project with a total distance of 1,500 railroad tracks with affection of more than 10,000 hectares of Mexico. Next slide. where workers are very much in extent contact with the previously undisturbed forest and in very much contact with vectors and reservoirs living there. Next slide. So the workers are also sleeping without a fine mesh protection and also have makeshift worksite in their camps and very highly exposed also with reservoir animals. Next slide. So the patients that we saw were more of a sentinel to know that there was something going on in the region of the Tren Maya. But in general, we can see here that in the Americas between 2001 and 2023, there has been a decrease of Leishmania cases. On the bottom, on light blue, we see a curve tending upward. That is the Mexico cases. This is opposite to what the trends in general in Latin American countries is. Next slide. The colleagues in the Centro de Medicina Tropical in the Mexican General Hospital are responsible for performing a lot of research in Leishmania in Mexico, and they led us to know that there had been a change of dynamic of patients. Returning travelers from South America or migrants had very resistant and aggressive forms of disseminated Leishmania. And together with the group of Ingeborg Beckmann, we were able to analyze a bit more of all of her findings. Next slide. We have not to forget the One Health perspective, which unites and links all of these different factors that I've mentioned before. Next slide. There has been a surge of migrants in Europe, but in Mexico, this is also the case. We are the gateway to the United States. So people from all over Latin America have to come through Mexico to travel on forward. We've had a surge in particular from migrants from Honduras and Venezuela. Next slide. And all of these migrants that travel on foot have to go through a region of Panama called the Darien Gap. This is a region of the Americas that has no roads. It is forcibly a region where they have to cross by foot or by boat. And this takes several days. And during this time, they are highly exposed not only to Leishmaniasis, but to many neglected tropical diseases. Next slide. So further challenges in migrant patients with Leishmaniasis are that due to their high mobility, it's very difficult to make a proper diagnosis. And the group from Ingeborg Beckmann also stated that they've identified multiple patients with Leishmania viania brasilensis, which is not normally endemic in Mexico. These patients also have the particularity that it's very difficult to isolate the mastigotes. You have to perform multiple smears to try to identify even one mastigote, even though patients have very evidently Leishmaniasis. And the issue is in Mexico that is if you don't have the presence of the mastigote, you are not provided the therapy. Next slide. So this poses a problem with treatment delay. And we also are unsure about what the vectors and transmission of the Leishmania brasilensis in Mexico are. They're not precisely defined. Next slide. So the surge of Leishmaniasis in southeastern Mexico is linked to human mobility. We spoke about the Tren Maya, but also workers coming from other parts of Mexico that had never been prior exposed to Leishmania and had no immunity were also very affected during the construction of the Maya project, the Tren Maya project. And as I spoke about, the international human migration with the surge of this very aggressive form of Leishmania brasiliensis. Next slide. So what is my takeaway message to you? Well, that Leishmaniasis is currently in Mexico re-emerging and is geographically expanding. And One Health drivers, including deforestation, migration, and wildlife reservoir dynamics are currently accelerating the spread. Next slide. So I'd like to complete my presentation now. Muchas gracias. Thank you very much for your attention. And if you have any questions, then after the three talks, I will be able to answer them.
Thank you very much, Gabi. That was a wonderful talk and a great overview of clinical aspects, public health aspects of Leishmaniasis in Mexico and Germany. You managed all that in 20 minutes, so thank you very much. I'm sure there will be many questions for you. But let's first continue with our second speaker for today. I'm very happy to introduce Dr. Antonio Jordán Ríos. He completed his clinical training in cardiology, heart failure, and transplantation, and later pursued a master's in public health at King's College London. After returning to Mexico, he has worked with vulnerable populations, including the Raramuri indigenous women living in the Sierra de Chihuahua, studying their cardiorespiratory fitness. And this group is apparently known for their ultra-distance running in mountainous terrain. In addition, his research focuses on heart transplantation in vulnerable groups, such as migrants in the United States of America and Maya indigenous communities. And he also works closely with nephrologists in a cardio-renal metabolic clinic, aiming to identify evidence-based strategies to reduce cardiovascular outcomes in the Mexican population. And currently, he is working at the Heart Failure and Transplant Clinic at the National Heart Institute in Mexico City. We are very happy to have you with us today and learn from your vast experience. Your talk is on global health challenges for emerging economies in Chagasic cardiomyopathy, and we're looking forward to it. I'm handing over to you, Antonio. Thank you.
Hello, thank you very much. Good morning from Mexico City and good afternoon over there. It's a real pleasure being here with you, and I'm really want to thank to Cristina, to Gabriela, and also to the whole team of the DTG webinar team for this invitation. So I'm a cardiologist, so as you might know, what I only know is about the heart, but I combined my cardiological expertise with public health challenges. So what I will be discussing with you today is challenges in Chagasic cardiomyopathy. I will be talking briefly about Chagas disease, but mainly I will be focusing on Chagasic cardiomyopathy. And at the end of the talk, I hopefully convince you that this disease is truly a global problem with 2 clinical cases. So let's start. So the clinical reality is quite complex. Chagasic cardiomyopathy has a complex pathophysiology that truly requires multidisciplinary teams that, first of all, are not always available across the country. And in the second part of this talk, I will be discussing some pressing issues in emerging economies that truly paralyze our system. So there is a very important burden of Chagas disease, specifically in Latin America. Most of the infected individuals are calculated around 6 to 7 million people. And from that cohort of patients, approximately 30 to 40% of them will develop at the end of the disease chronic Chagas cardiomyopathy. In other words, around 40% of the population infected with Chagas disease will develop an affection in their hearts. And mortality is quite high. 3 years mortality is estimated at 56%. And you can see on the right-hand side of the screen, the Chagas cardiomyopathy has the worst prognosis of other different types of heart failure. When we analyze ischemic heart failure, non-ischemic heart failure, and Chagasic heart failure, you can clearly see that the group of patients with the parasite has the worst prognosis of them all. And I would like you to remind just 4 important topics in the way this parasite affects the heart. Point number 1, what we have here is that the parasite, which is known as Trypanosoma cruzi, once the parasite enters the bloodstream, it goes to the cells of the heart, to the myocytes, reproduces, and starts damaging the cells. And the result is a chronic inflammatory and a chronic fibrosis process in the heart tissue. A second problem is that patients develop apical aneurysms that are these little bumps here that you can see on the apex of the heart. And these aneurysms are really problematic because they are a source of thrombus, which can embolize to the brain. There is also important microvascular derangement because of capillary thickening abnormalities. And finally, but not least less important, we need to remember that Chagas also present with dysautonomia. That means that there is an important severe parasympathetic denervation process, which makes the patients really hypotensive, and they tend to be like fainting all the time. This is the timeline of how the infection affects the heart. We have first an acute phase where the patient is extremely rarely detected. It's a very brief period of window of opportunity, but sometimes, or most of the times, I mean, it's lost. Then we have an indeterminate phase, which normally takes decades in a silent way. But in this phase, we can detect the patient with positive serology. Sometimes the ECG starts showing us a specific alarm signals through the ECG. And then we have finally the last phase of the disease, which is known as the chronic Chagas cardiomyopathy phase, which is basically an end-stage heart failure stage where no medication is able to help the patient, and when heart transplantation is basically the only option for these patients. So the window closes right here, and the public health window of opportunity is the intermediate phase, designing important policies to screen population at risk before they develop irreversible remodeling fibrotic process in the heart is crucial to stop this disease. Now, how to diagnose? So we need a serological standard that is considered the gold standard for diagnosing the infection. On the right-hand side, on the right-hand side of the screen, you can see we have an acute patient. What we need to do is a direct parasitological detection with a PCR testing. And if we have a chronic phase, which is most of our patients, because as I mentioned previously, there is a long period of a silent disease where the patient feels nothing. Then for the majority of patients, you need two different serological tests to confirm, either an ELISA or an IFA. When the patient is starting the last phase of the disease, when the heart is starting to get bigger and bigger and the cardiomyopathy gets present, here you can see that there are very subtle signals that you can detect on the ECG that really triggers that somebody needs attention. For example, a right bundle branch block novel development, somebody that previously did not have a right bundle branch and now he or she develops, it's an important red flag. A left anterior fascicular block, as I mentioned, it's also an important red flag. And the most important one is the arrhythmogenic markers, which means premature ventricular contractions. We should not wait until the patient develops a lethal arrhythmia, such as a ventricular fibrillation, but we should screen patients who start having premature ventricular beats because they might be in danger. And once you have a suspicion by an ECG, and then you might perform the ELISA or the serological testing, you can have three different imaging methods to document that the function of the heart is indeed decreased and the cavities are dilated. And the first line imaging test method is the echocardiogram. As all of you know, it's a first line method because it's widely accessible and it really provides prognostic information such as ventricular ejection fraction and the presence of apical aneurysms that I mentioned that they are very problematic. But sometimes, as echo is the first line method, the gold standard is the CMR, the cardiac magnetic resonance, because it is the only imaging method that is able to characterize the tissue. CMR provides us in percentage how the degree of fibrosis of the heart, and also detects, for example, the presence of late gadolinium enhancement, which is a specific marker that CMR provides, and it's also crucial for prognosis in Chagas patients. Those who develop late gadolinium enhancement are at higher risk of progression and at higher risk of mortality. And I will not discuss nuclear imaging because it is not really being used on a daily basis. So CMR or cardiac magnetic resonance really informs us the substrate of the disease. You can see these patchy areas here are fibrotic areas that trigger lethal arrhythmias. and frequently our patients experience sudden cardiac death without access to implantable cardioverter defibrillators or without access to highly specialized centers where they can be transplanted. So CMR is important because it helps to give prognosis, and CMR guides treatment for deciding who might be a suitable candidate for implantable cardioverter defibrillator. The problem again is access. CMR or magnetic resonance is definitely not widely available in Mexico, so we have an access problem to the diagnostic method itself for the heart. Yes, we have different scores, and as every score, they have their different caveats, but you can see here that the clinical risk stratification is different according to the score that you might use. The first one of the left-hand side is the RASI score, which predicts 10-year mortality, and sometimes we use it to predict those patients who are sick enough to need heart transplantation. And then we have the SOSA score, which is a specific score a Brazilian score, by the way, specifically designed to predict sudden cardiac death. And this one helps us to decide whether the patient might be a candidate for the ICD implantation or not. What can we do for the chronic cardiomyopathy patients, those who have already finished the intermediate window, those who did not have the chance to get diagnosed? What can we do? Once the patient develops heart failure with reduced ejection fraction, to be honest, evidence has been extrapolated from major clinical trials. And when we analyze the evidence into a meta-analysis fashion, we have demonstrated, we have found that definitely no heart failure medication is beneficial in reducing mortality and cardiovascular hospitalizations for these patients. So despite the fact that we have a broad range of medications to treat contemporary HFrEF or heart failure with reduced ejection fraction, all the contemporary medication is not proven to be safe and efficacious in these patients. Because the patient with Chagas cardiomyopathy is unique. It has a very fibrotic phenotype, and Chagas patients historically have been highly underrepresented in landmark clinical trials. Therefore, evidence is very, very scarce, and no current pharmacotherapy is useful for patients who start this disease. Until 2028, where the Parachute HF trial was designed, the Parachute HF was was designed to test the hypothesis whether sacubitril valsartan is useful in reducing cardiovascular death or heart failure hospitalization and the change of NT-proBNP. The trial was unfortunately negative and did not reach its primary endpoint. So far, sacubitril valsartan is not useful for these patients. What about arrhythmia management, which is, by the way, the leading cause of death for these patients? There have been the amiodarone, which is a historical drug that is very useful, is highly efficacious for suppressing the acute episode of an arrhythmia, but it has important toxic. It has an important toxic profile for long term. So definitely, amiodarone is not a long-term solution for the leading cause of death of these patients. What about ICD? What the evidence says? So the Chagasic trial was a Brazilian randomized clinical trial that has recently published its final results, and unfortunately was also negative to demonstrate whether implanting an ICD on Chagas patients for primary prevention was useful. So it looks like we are getting with no more options, no pharmacotherapy, no contemporary drugs, no ICD for these patients on the view of the Chagasic trial, although I would like to open brackets and say that Chagasic trial was severely underpowered to reach its primary endpoint, but it is what it is. The trial was negative. What about antiparasitic therapy for chronic Chagasic cardiomyopathy? So we have two different drugs, two different antiparasites, benznidazole and nifurtimox. first-line treatment is besnidosol because it was tested in a randomized clinical trial, which was the BENEFIT trial, which also was negative to demonstrate any benefit in reducing hard cardiovascular outcomes. It did not reduce cardiovascular events. It did not reduce mortality. It was able indeed to eradicate parasite count, but all the damage was not reversible in the heart. So benznidazole is not an option for us in cardiology, and it is also not an option because it's not available in Mexico, by the way. We only have nifurtimox, which is fairly useful for the acute phase or the intermediate phase, but once again, not for the chronic patient. So this needs a comprehensive multidisciplinary team. This needs a very robust infrastructure. You need a very high specialized center because you not only need a cardiologist, you need a pharmaceutical team, nutritionists, nurses, a heart transplantation team, surgeons, rehabilitation. So the complexity goes beyond frontiers. Now let's go from the clinic to the community. There is, as Gabby mentioned, an important rural endemic to global urban areas. This pandemic of Chagas disease really affects millions of people around the world. And what is highly striking is that around 300,000 people in the United States live with a positive Chagas diagnosis. This number is approximately the same number of people dying from breast cancer every day in the United States. So it's an important number to take into account. How can you get Chagas disease? So it's a vector disease, which is historically transmitted by this bug, which in Spanish is named chinche besucona. And the bug bites the host. And while the bug is biting and like sucking a little bit of blood, at the same time, the bug produces feces inside the skin. So the feces contains the parasite, and the feces go into the bloodstream and infect the whole body. The second route of infection is oral or foodborne, specifically in the Amazonian region, where there have been reported important cases of contaminated acai, which is a fruit, and sugarcane juice, which is also found in the Amazonian forest, which are contaminated with the parasite. Also, we have the congenital borne and also for contaminated blood transfusions. So this is a zoom of the bug, the chinche besucona, which transmits the parasite, which is the Trypanosoma cruzi in a blood smear that you can see there. This is part of the dissociation that we find in Chagas disease, and probably this natural history of the disease explains the way that we catch patients in a very late time. Once sometimes it's very, very late to do something. Chagas disease is also very challenging because we face high-risk populations, which they are at high risk of reactivation. So when patients reactivate their parasite count, it's a catastrophic clinical emergency, and normally nobody survives to a reactivation hot phase of this disease. This is something invisible because sometimes it's only diagnosed when the patient is in chronic heart failure stage. And in other countries, when the patient arrives to an emergency system or an emergency clinic with a heart failure scenario, they normally do not think in Chagas. They just think, oh, it's just another heart failure patient. It's just another dilated heart failure patient. But it's truly an invisible global reality that we need to do something for that. There are promising solutions. For example, in Brazil, they have developed serological point-of-care diagnostic tests, the RDTs. These are serological tests that are ready in less than an hour, but I need to say that they do not have high sensibility for the Mexican population because the genetic of the parasite is different from Brazil to Mexico. So these tests that are very fast are not a solution for us in Mexico. We need to validate them, and so far they have not been given good results. So this is just for giving just my last minutes of my presentation. We will be discussing two clinical cases. I will start on the left-hand side, a 54-year-old gentleman, originally from Mexico, from Campeche, but he works as an immigrant in Canada. He works with oil, with the canola seed to produce oil. So he was diagnosed in 2019. He developed Chagasic dilated cardiomyopathy with an ejection fraction of 31%. And an ICD was implanted in 2023. In 2025, he developed progressive functional of her clinical status, advanced heart failure criteria, and he was referred to our center via telemedicine from Canada, and we admitted in our hospital. This case was presented last year at the European Congress of Cardiology in Madrid. The second patient, as you can see, again, global health issues, second-year-old male, originally from El Salvador, but currently he is unemployed and currently a resident in Mexico City. He also has Chagasic dilated cardiomyopathy, ejection fraction more severe, 27%, and he has already developed lethal arrhythmias, sustained ventricular tachycardia. This is a class 1 recommendation for implanting an ICD because it's secondary prevention. And despite having an ICD, lethal arrhythmias persisted, and he underwent an epicardial ablation. Then the ICD generator was empty, and he needed a replacement. And 2 years ago, he was hospitalized for an electrical storm, which is a severe arrhythmia with hemodynamical instability. So this is the journey that patients from the global north take to come to the global south. He is Mexican, working in Canada. This is our first case. He developed symptoms in Canada. He contacted us by our telemedicine program, which is a program, by the way, designed to give and provide attention to migrants in the United States and Canada. And he was referred to our hospital, the National Institute of Cardiology, where we started to study the patient, to work up the patient. You can see the ECG, red flags, clearly red flags, a right bundle branch. You can see an echo, a very dilated left ventricle. And then this is the second patient, the one that developed the electrical storm. Just to take a look at the ECG, this is a sustained ventricular tachycardia despite having an ICD. So the patient was receiving repeatedly different shocks of the ICD because of the arrhythmia. So we need to control the arrhythmia. And then these patients had no more solution than considering them candidates for a heart transplantation. So you can see here that we decided to perform a right heart catheterization in order to see how the pressures were in the lungs. And then we finally transplanted the patient. This is the histopathological piece of the patient. Just look at the heart. It's a very big heart. The weight was calculated in 400 grams, and the patient was successfully transplanted. Just I would like to open brackets and would like you to know Difurtimox was initiated in these patients. As I mentioned previously, antiparasitic drugs such as Nifurtimox or Benzidamol, they have no evidence to work, to give positive results in advanced heart failure. But there is one exception, which is heart transplant. When you are listing somebody for a heart transplantation, you definitely need to administer the antiparasitic drug. Otherwise, once the patient is transplanted and immunosuppressed, the viral count, the parasitic count can go very high, and the patient can die just hours. This was the second patient, who was also transplanted. Here you can see some histological specimens that show how big the heart is in these patients. And from this histopathological image, you can see also that all the myocytes are deranged and they have a lot of fibrosis inside the tissue. So just for finishing, these are my take-home messages. Advanced Chagas cardiomyopathy is highly complex. These two cases that I mentioned really underscore the importance of different strategies such as telemedicine, different strategies of global health that can provide access to patients that live in other countries. We need to establish strategic priorities for global cardiology. For example, decentralized diagnostic innovation. We need to launch dedicated clinical trials for answering more complex questions. And we also need to have important surveillance and global vigilance. So thank you very much, and looking forward for the discussion.
Thank you very much, Antonio. I think that gave all of us a very much better understanding of the actual cardiological consequences of Chagas disease. And also thank you for demonstrating this global relevance that is definitely underestimated. I'm sure there will be a lot of questions for you also, but we will just wait until we heard from our last speaker for today. Let me introduce Dr. Javier José Hernández Buen. He is a medical doctor who trained in internal medicine in Mexico and worked there for 3 years in infectious diseases before he moved to Germany, where he completed a diploma in tropical medicine and public health at Charité in Berlin. And he is currently working as a research physician and principal investigator at Charité Research Organization, overseeing phase 1 to 3 clinical trials. We are very happy to have you here.
Thank you. Thank you very much for the introduction. Let me just correct one thing. I work at another clinical research organization. I don't work right now at the Charité.
Okay, sorry. Sorry about that.
No problem. But thank you very much for this nice introduction, and thank you all for being here. Today I'm discussing histoplasmosis, a fascinating and clinically important topic, and I'll try to cover comprehensive information in 20 minutes using a clinical case approach. Through this patient's story, we'll see how the significant challenges of histoplasmosis actually manifest and how we can navigate them. So our case setting is Mexico City, which is the capital of Mexico in the middle of the country. And to understand our patient's journey, it's important to appreciate the healthcare context in Mexico City. Mexico City has approximately 25 million people, and the health system, as you can imagine, operates at full capacity with scarce resources and long waiting times. Mexico's health system is highly centralized. Major hospitals and specialized physicians are concentrated in Mexico City, making it a reference center for the entire country. Also, patients arrive from all regions. This means we encounter every disease in every presentation and every degree of complications. When approaching differential diagnosis for infectious diseases, we must maintain broad clinical suspicion and consider endemic diseases from across the country. Our patient presented to a general hospital in Mexico City, and the infectious disease department of this general hospital works closely with the National Institute of Respiratory Diseases, where specialized diagnosis tests are performed. And this collaborative relationship between these two hospitals was essential for confirming the patient's diagnosis. Now, let me introduce our patient and his clinical presentation. So Juan is a 45-year-old male originally from Chiapas. This is a state south in Mexico. And he currently resides in Mexico City, where he works as retail counter worker. He is single with no household contacts and reports no use of drugs or allergies. Importantly, Juan denies any recent travel in the past 2 years. Specifically, he has not traveled to the north or south of Mexico. And this detail is clinically significant because it suggests his exposure to histoplasma likely occurred either during his early residency in Chiapas or through environmental exposure in Mexico City itself. The patient's past medical history is notable for a significant infectious diseases. He was diagnosed with pulmonary tuberculosis in 1995. He received standard of care and apparently complete the full course. We believe his current tuberculosis status is negative, meaning he is not currently infected. Now the case becomes considerably more complicated. The patient was diagnosed with HIV in 2012, presenting with pneumocystis jirovecii pneumonia, an AIDS-defining condition with a CD4 count of 32 and a viral load of 25,000 copies. He was treated and started on Atripla, which is efavirenz, tenofovir, and emtricitabine. And just to notice, Atripla was an excellent choice 14 years ago. It had the advantage of having fewer drug-and-drug interaction, but an important aspect of one of the drugs is that efavirenz is associated with significant central nervous system side effects, especially with psychiatric symptoms. The patient adhered to this regimen for 12 years, and his HIV remained controlled. And while following the principle of if it ain't broke, don't fix it, the regimen continued unchanged. And we have no documentation of other opportunistic infections or additional prophylactic medications during this period. In April 2024, after 12 years on a triplet, the patient's regimen was changed due to efavirenz-related neuropsychiatric side effects, and a new regimen with Biktarvy containing bictegravir, tenofovir, and emtricitabine was started. The patient tolerated this regimen for 7 months. However, in November 2024, the patient self-discontinued antiretroviral therapy against medical advice. By December 2024, his viral load has skyrocketed to 40,000, and his CD4 count had plummeted to 64 cells per microliter. And this case illustrates a critical principle. Non-adherence is the #1 preventable cause of treatment failure and opportunistic infections. So with this profound immunosuppression as a backdrop, let's examine the patient's presenting symptoms. The patient presented with a subacute multisystem illness evolving over 4 months period. So 4 months ago, the patient developed headache, persistent fever, anorexia, and progressive visual acuity decline. 3 months ago, non-inflammatory diarrhea began. An external physician prescribed trimethoprim sulfamethoxazole, and the patient experienced partial improvement, a clue suggesting one of the opportunistic infections component. 2 months ago, the patient developed dry, non-productive cough and progressive weakness of lower extremities affecting ambulation. Notably, he denied dyspnea or chest pain. So this subacute multi-system presentation is the key clinical pearl. The combination of central nervous system, respiratory, gastrointestinal, and constitutional symptoms over 4 months strongly suggests a disseminated infection rather than a localized disease. Let's examine what the physical examination revealed. On physical examination, the patient appeared frail, pale, and cachectic. Neurologically, the examination was normal except for bilateral lower extremity weakness, 4 out of 5 with normal reflexes. Pulmonary examination revealed diminished vesicular breath sounds with diffuse, dry, and inspiratory crackles. Abdominal examination was normal. Vital signs showed fever, tachycardia, and hypoxia. And given this severely immunocompromised patient, opportunistic infection is the most likely primary culprit. A clinical aspect that I want here to mention is that we must remember regular pathogens, like, for example, infections with Streptococcus pneumonia, still cause disease and may coexist with opportunistic infections. And there are different differential diagnoses in this case, like Mycobacterium tuberculosis, Mycobacterium avium, virus like cytomegalovirus, with the patient presented with retinitis, colitis, and encephalitis. We must remember that HIV encephalopathy alone could explain the progressive neurological decline. But the 3 major culprits could be pneumocystis jirovecii. The patient has already presented like this and have hypoxia and a CD count less than 200, Cryptococcus neoformans, and Histoplasma capsulatum. Since it's endemic in Mexico, the patient presents with fever, cough, and probably disseminated disease. So let's examine the diagnostic workup that was performed. The lab workup revealed multiple critical abnormalities. Complete blood count showed severe pancytopenia with neutrophils of 500. And a clinical case is that neutropenia, specifically less than 1,000, is a significant risk factor for fungal infections. Hemoglobin and thrombocytopenia was also noticed. Electrolytes showed disturbances, but renal function was normal, though we must remember the patient is cachectic, making creatinine levels unreliable as true measure of renal function. Liver function tests were abnormal, and most notably, lactate dehydrogenase was markedly elevated. And this is critical clinical peril. And while HIV patients can have elevated LDH per se, 2 infections particularly elevate LDH, pneumocystis jirovecii and histoplasma. And this finding was highly suggestive of any of these microorganisms. Ferritin was also markedly elevated, far exceeding normal values. And while disseminated histoplasmosis causes elevated ferritin, such extreme elevations is more characteristic of a secondary problem. The patient had also hypo or low fibrogen, and high triglycerides that are suggestive of another serious diagnosis that I will discuss later. Patient with immunosuppression and fever needs always blood cultures, and any patient that comes with a clinical suspicions of a probable meningitis will always get a lumbar puncture if there is no contraindication. So the blood cultures were negative. The CSF culture, this is the cerebrospinal fluid, was also cultured. The bone marrow culture and the CSF mycobacteria culture were pending. The lumbar puncture had a normal opening pressure, and while this does not completely exclude cryptococcal meningitis, it makes it a little bit less possible, but it did show hypoglucurachia and hyperproteinorachia with mild pleocytosis, findings consistent with an aseptic meningitis, probably a fungal or tuberculosis meningitis, blood BGA, and normal lactate. The CT shows a characteristic macronodal pattern with peripheral and basal distribution, multiple consolidations and ground glass opacities in both hemithoraxes, as you can see here, with also a pulmonary collapse, macronodals all around the peripheral. And these findings are highly characteristic of acute pulmonary histoplasmosis. However, other superimposed infectious etiologies, including pneumocystis jirovecii pneumonia, cannot be excluded. Now that we've reviewed our patients' clinical presentations, let's explore the underlying pathogen and understand why histoplasmosis should be high on our differential diagnosis. Histoplasmosis is caused by two main species of histoplasma that infect humans. This is Histoplasma capsulatum, subspecies capsulatum, with a second important variant being Histoplasma capsulatum subspecies duboisi. What makes histoplasma particularly interesting from a microbiological standpoint is that it is a dimorphic fungus, meaning it exists in two different or distinct forms depending on its environment. Before we move forward, it's important to recognize that this histoplasmosis represents a significant public health challenge and is considered a neglected tropical disease, and understanding why is crucial for clinicians and for our diagnosis. Misdiagnosis is a major problem. In endemic areas, histoplasmosis is frequently mistaken for tuberculosis, leading to incorrect treatment and devastating consequences. Mortality rates hover around 30%, even when patients are receiving treatment. Access to diagnosis is severely limited. While commercial antigen tests can provide rapid diagnosis of disseminated histoplasmosis, these tests are rarely available in high-burden, low-resource settings where the disease is most prevalent. This diagnostic gap perpetuates delayed recognition and treatment. Surveillance is fragmented. Histoplasmosis is not a notifiable disease in many countries. And perhaps most clinically relevant to our discussion today, histoplasmosis is a leading opportunistic infection in advanced HIV disease. Now let's examine the epidemiology in greater detail. Historically, histoplasmosis was considered an endemic fungal infection restricted to specific geographic regions. However, our understanding has evolved considerably. We now recognize that Histoplasma capsulatum has a much broader global distribution than previously appreciated. It has been identified on every continent, including Antarctica. What's driving this expanding recognition? Well, several factors. Climate change is altering fungal ecology. We have increasing number of immunocompromised hosts, like our patient with advanced HIV, and there is significant geographic variability with hyperendemic regions where disease prevalence is exceptionally high. Additionally, outbreaks can occur both within these highly endemic areas and in regions where we might not traditionally expect them. In our modern world of global commerce, migration, and tourism, distinguishing between autochthonous cases, those acquired locally, and cases related to external exposure has become increasingly challenging. The diagnostic consideration is particularly relevant when evaluating patients like ours. North America, particularly Mexico, but also Central and South America, show a high endemicity with seroprevalence exceeding or about 20% in most countries. Now, let's focus on Mexico specifically. Histoplasmosis is endemic throughout Mexico, with cases reported in 23 of the country's 32 states. And in Mexico, the primary risk factor comes from handling droppings of domestic birds such as hens and parakeets. There is also accidental contact with wild birds in natural environment. However, the greatest risk comes from bat guano, which harbors high concentration of infectious spores. Mexico's National Epidemiological Surveillance System was in charge of reporting these cases. However, in 1995, case notification became voluntary rather than compulsory, resulting in a dramatic decrease, of course, in reported cases. Today, our epidemiological knowledge of histoplasmosis in Mexico relies primarily on case series and outbreak reports rather than systematic surveillance. The epidemiology of histoplasmosis in Mexico is shifting. Historically, it was recognized as an occupational disease affecting miners, farmers, and guano collectors. However, researchers are now observing an increased number of cases in low endemicity areas, including urban centers like Mexico City. So the slides show a retrospective study of 61 patients diagnosed with histoplasmosis at Mexico's National Institute for Respiratory Diseases, and notably 38% of patients live in Mexico City, of this 61, a low endemicity area, and only about half had traveled to high endemic regions. 80% of patients, of these 61 patients, had no occupational risk factors whatsoever, and 80% of these 61 patients had a history of immunosuppression, with 94% had an HIV infection as the underlying cause with a very low CD4 count. Another interesting study was published last year in the PLOS Neglected Tropical Diseases, and it provides critical insights into the true burden of progressive disseminated histoplasmosis in our region. Among the 415 hospitalized patients with HIV with fever, histoplasmosis emerged as a leading cause, accounting for 38% of the cases, surpassing tuberculosis and pneumocystis pneumonia. However, a critical challenge persists during this study. Histoplasmosis and tuberculosis are clinically indistinguishable. And while tuberculosis more commonly presents with lymphadenopathy and pleural effusion, histoplasmosis typically features skin lesions, cytopenias, and elevated LDH, but this overlap frequently lead to misdiagnosis and empirically anti-tuberculosis treatment, with histoplasmosis sometimes even recognized only after death. Regarding the clinical manifestations, the majority of histoplasmosis infections, approximately 90%, are asymptomatic or subclinical, and acute pulmonary histoplasmosis typically develops 1 to 3 weeks after inhalation and is usually self-limited in immunocompetent hosts. Common symptoms include cough, dyspnea, chest pain, and chest imaging typically shows patchy bilateral opacities, often with hilar or mediastinal lymphadenopathy. And additionally, about 5% of patients develop rheumatological and dermatological manifestations, including erythema nodosum, erythema multiforme, and arthritis. These extra pulmonary manifestations represent a hypersensitivity response to fungal antigen. And because these symptoms and imaging findings are non-specific, pulmonary histoplasmosis is frequently mistaken for a community-acquired pneumonia, usually delaying diagnosis. Now, on the slide, you can see a chest X-rays from an 18-year-old patient without comorbidities who developed dyspnea and fever after exposure to an abandoned building. Histoplasmosis was diagnosed, and the X-rays show a reticulonodular pattern. In patients with high fungal inoculum or severe immunosuppression, severe pneumonia with acute respiratory distress syndrome can develop. And you can see here the high-resolution chest CT scan of an HIV patient non-adherence to antiretroviral therapy confirmed disseminated histoplasmosis present with fever, dyspnea, and dry cough. It says, notice the randomized micronodal pattern characterized of this disseminated disease. Beyond acute presentation, histoplasmosis can manifest as chronic pulmonary disease with distinct clinical and radiographic features. It's unusual, and the differential diagnosis is always with tuberculosis. It can also present as pulmonary nodules, which may be indistinguishably from malignancies. There's also the complications and can evolve in the mediastinum, presenting from asymptomatic findings to life-threatening complications, asymptomatic lymphadenopathy, granulomatous mediastinitis with caseation and necrosis, and even mediastinal fibrosis, usually after infection. And in severely immunocompromised hosts, histoplasmosis disseminates hematoiously, causing severe extrapulmonary manifestations that can be rapidly fatal. And while traditional seen in advanced HIV with low CD4 counts patients, infection is increasingly recognized in other immunocompromised patients like with hematological malignancy, solid organ transplant, and those receiving TNF-alpha inhibitors. And patients present with systemic symptoms can rapidly progress to shock, respiratory failure, adrenal insufficiency, and hemophagocytic lymphohistiocytosis. Laboratory findings include pancytopenia, liver function dysfunction, and elevated ferritin. The most common signs of involvement are liver, spleen, lymph node, and bone marrow. And given the rapid and severe progression of disseminated disease, prompt diagnosis is critical. So let's explore some diagnostic tools available to confirm histoplasmosis. Culture remains the gold standard for diagnosis. However, culture has significant limitations. Its growth typically requires 2 to 4 weeks. It's impractical for timely diagnosis and treatment, and the sensitivity varies with the disease burden. Histopathology can identify also histoplasmin infected tissues, but more importantly, antigen testing is a recommended diagnostic test for persons living with HIV. It can be performed on blood, urine, cerebrospinal fluid, and bronchoalveolar large specimens, and antigen testing demonstrate the highest sensitivity in disseminated diseases and also show high sensitivity in acute pulmonary histoplasmosis, around 83% for urine antigen, and on chronic pulmonary disease, almost 88%. Also on cerebral spinal fluid, the antigen is about 78% sensitive. There are important limitations like cross-reactivity with other fungi, blastomyces, parasitoides, aspergillosis, and limited availability in resource-poor setting. There's also antibody testing, and there are new emerging diagnostic approaches, including next-generation sequencing like fungal sequencing targeting ribosomal RNA and microbial cell-free DNA in blood. This is summarized of the differential diagnosis and what are the sensitivity for them according to each clinical presentation. Now let's return to our patient. Due to pancytopenia, bone marrow biopsy was performed which showed granulomatous inflammation with fungal microorganisms morphologically and histochemically consistent with histoplasma species. And additionally, urine histoplasma antigen testing was positive, providing rapid confirmation of disseminated disease. Additional testing ruled out alternative diagnosis. So the final diagnosis is based on clinical presentation, medical history, and all the lab findings. It's disseminated histoplasmosis with central nervous system involvement. And pneumocystis jirovecii pneumonia was also diagnosed. And this was complicated by a secondary HLH or hemophagocytic lymphohistiocytosis, which can present in patients with severe disseminated histoplasmosis, and it's just an hyperinflammatory syndrome with excessive immune activation and cytokine release. And characteristic in this patient is an elevated ferritin, LDH8, but also hypertriglyceridemia, which is interesting in this case. Management of histoplasmosis varies significantly depending on disease, severity, immunological status, and clinical presentation. Acute histoplasmosis in immunocompetent patients with mild to moderate symptoms is often self-limited. If symptoms persist beyond 4 weeks, itraconazole 200 milligrams once or twice daily for 6 to 12 weeks is recommended for severe acute disease, require liposomal amphotericin B for 1 to 2 weeks, followed by itraconazole, and then systemic corticosteroids can be considered in severe acute pulmonary histoplasmosis. Something interesting is that recent studies have shown that liposomal amphotericin B accumulates in the reticuloendothelial system and other tissues for several weeks after administration of a dose, which opens the door for shorter durations of infusion since amphotericin B is liposomal is quite expensive and it has several adverse events. Chronic histoplasmosis requires 12 to 24 months of itraconazole, and tobacco cessation is quite important. For disseminated histoplasmosis, particularly in severely immunocompromised patients, we also do an induction with liposomal amphotericin B up to 2 weeks until clinical stabilization, and then itraconazole for a minimum of 12 months. And this changes a little bit when there's a presentation involving aseptic meningitis. So The extended induction therapy is recommended for 3 to 4 weeks of liposomal amphotericin B, followed by itraconazole for at least 12 months. And the CSF analysis should be repeated at therapy completion to confirm resolution of abnormalities, including clearance of histoplasma antigen. Antiretroviral therapy should be initiated promptly. And immune reconstitution syndrome is uncommon during disseminated histoplasmosis treatment. And patients developing severe respiratory complications should receive methylprednisolone. Beyond first-line therapy, we must consider treatment acceptability, toxicity, management, and alternative agents, particularly in resource-limited settings. Acceptability of treatment is critical. Suboptimal adherence to antifungal therapy is associated with relapse and mortality in persons living with HIV with disseminated histoplasmosis. In resource-limited settings where liposomal amphotericin B is unavailable or expensive, the oxycolate amphotericin B can use for 2 weeks. However, comparative studies demonstrate liposomal amphotericin B is quite superior with 82% clinical success versus 56% with the other amphotericin, also lower mortality and significant less nephrotoxicity. Alternative triazoles have been explored in some small studies, but until now, perhaps isovoconazole, which demonstrated efficacy in the VITAL trial, could be used, but also rarely available, and it's also quite expensive. There are new forms and new antifungal that have been are under studying for histoplasmosis. Our patients receive a multimodal treatment approach addressing all aspects of this complex disease: antifungal therapy, methylprednisolone, trimethoprim sulfamethoxazole, and nutritional therapy. The patient was discharged after a month of treatment. Unfortunately, as it happens very often in our settings, the patient was lost to follow-up. So just finishing the presentation, let's address prevention, prophylaxis, and prognosis in histoplasmosis. So the best prevention is to reduce the risk factors. And for occupational risk factors, using appropriate equipment is encouraged. Eventually, the use of itraconazole could be recommended. Also, remember recreational activities in endemic areas such as cave exploration also pose infection risk, as illustrated in this article from a newspaper in Mexico. The patient went to a cenote, which is this like sinkhole in the ground, and it's quite beautiful, but it's full of sometimes of histoplasmosis. For patients with CD4 and HIV and CD4 below 150 and endemic areas, prophylaxis with itraconazole is recognized, and the prognosis depends critically on immunological status and disease severity, but up to 30% despite treatment die of disseminated histoplasmosis and HIV. And I just want to show you this quick paper published on PLOS Global Public Health, and it's a cost-effective analysis demonstrate that routine histoplasmosis antigen screening in persons with advanced HIV disease avoids an estimated 70% of AIDS-related deaths, and routine screening provided highly cost-effective when an incremental cost-effectiveness ratio of only $26 per life year saved. So the analysis demonstrates that histoplasmosis antigen screening is not only clinically beneficial, but economically feasible. As we conclude, let me highlight 5 critical take-home messages from this case. So histoplasmosis is a neglected tropical disease with high mortality, often misdiagnosed as tuberculosis. Maintain high clinical suspicions in endemic regions, especially immunocompromised patients. Non-adherence to antiretroviral therapy is the #1 preventable cause of opportunistic infections. In HIV patients with CD4 less than 200, histoplasmosis becomes a leading opportunistic infection. Disseminated histoplasmosis presents as multi-system disease with non-specific symptoms, fever, cough, diarrhea, and irregular involvement, mimicking other opportunistic infections. An early diagnostic workup is critical. Antigen testing on urine, blood, and cerebral spinal fluid is the gold standard for rapid diagnosis in HIV patients. And do not delay treatment while awaiting test results or if diagnostic tests are unavailable in your setting. High clinical suspicion warrants empiric antifungal therapy. Early diagnosis, prompt liposomal amphotericin B induction, immediate antiretroviral therapy, and prolonged itraconazole consolidation significantly improve survival outcomes. Thank you very much for your attention. But more importantly, I hope my colleagues and I haven't discouraged you from visiting Mexico.
Thank you very much, Javier. I think everyone is very interesting and probably interested and probably keen to visit Mexico now after all your interesting talks. So we now have some time for questions. The floor is open to all of you. I think there was already a little discussion going on in the chat between Mirna and Antonio on the difference between, I think, Chagasic and non-Chagasic cardiomyopathy and the outcomes. I don't know if you want to summarize that quickly, Antonio, just for the
just
audience.
pointing out, and thank you very much to Mirna. So in secondary prevention, that means those who have already had a ventricular tachycardia, there is no doubt that an ICD would help to prevent further arrhythmic events. And when you implant an ICD in a Chagasic cardiomyopathy versus a non-Chagasic cardiomyopathy, outcomes tend to be similar. I mean, the rate of infection, the rate of exteriorization of the device, the rate of duration of the battery, those outcomes tend to be the same. In primary prevention is the challenge. Primary prevention would be that patient that has never in his life or her life experienced an arrhythmia, and then you wonder whether he or she needs an ICD because of ejection fraction, because of fibrosis, because of your inner fear of the patient, whatever. And that was the Chagasic trial that tried to answer that question, ICD in primary prevention, and seemed to be no benefit for those patients. So what we do in clinical practice, we really try to tailor these patients, and we really try to see just instead of just one visitation, we try to look at the trajectory